Saygıdeğer hocalarım, sevgili meslektaşlarım, Türk Radyoloji Derneği İstanbul şubesi ve Pediatric Large Derneğinin ortak düzenlediği Pediatric Large Sempozyumuna hoş geldiniz. Bu sempozyum bizim ikinci ortak sempozyumumuz. Geçen sene Sayın İbrahim Hocam'ın başkanlığında bir sempozyum yapmıştık. İbrahim Hocam'ı göremiyorum. Hocam arkaya oturmuş. Bu bizim ikinci toplantımız. Çok değerli bir konuğumuz var tabii ki bu sefer. Sempozyumumuz 2 oturumdan oluşuyor. Arada 20 dakikalık bir aramız olacak. İlk oturumu başlatmak üzere Türk Pediatric Radyoloji Derneği Başkanı ve benim Sayın Hocam Abdülhakim Coşkun'u buraya davet ediyorum. Buyurun hocam.
Zaten ufak bir giriş yapacağız, yoksa konuşmayacağız. Arkadaşlar, gerçekten çok güzel bir iklim, pazar sabah buraya gelmeniz gerçekten memnun edici. Çocuk Radyolojisi Derneği bildiğiniz gibi genç bir dernek. Şu an 81 üyemiz var. Zannediyorum bir 8-10 kişi de bu yıl katılacak. Dolayısıyla yavaş yavaş 100 sınırına doğru, sayısına doğru yaklaşıyoruz. Bugünkü toplantıda aslında bir sempozyum yapmayı planlamıştık. Malumunuz daha geniş çaplı 2,5 gün sürecek bir Middle East Çocuk Radyolojisi Sempozyumu. Ancak bazı nedenlerle iptal etmek durumunda kaldık maalesef diyelim. Önümüzdeki hafta bu sempozyum Katar'a taşındı. Dolayısıyla ilgi gösteren arkadaşları çok gerçekten güzel, doyurucu, tatmin edici bir çocuk radyoloji sempozyumu olacak. Ben de, Burcu da, birkaç arkadaş katılıyoruz. İçinizde ilgi gösterenleri de davet ediyorum özellikle. Boston Children's Hospital, duymuşsunuzdur hepiniz. Amerika'daki en iyi 3 çocuk hastanesinden birisi. Genelde ya birinci oluyor. Philadelphia çok var Children's Hospital Pediatrics. Dolayısıyla bu iki hastane, yine Toronto'da Sick Children, bunlar genelde hep ön sıralarda yer alıyor. Dr. Lee de Harvard School'a bağlı olarak Boston Children's Hospital'da 15 yıldır görev yapıyor. Chicago'da radyoloji eğitimini aldıktan sonra Children's Hospital'da eğitimini tamamladı çocuk radyolojisiyle ilgili ve ondan sonraki tüm akademik kariyeri orada devam ediyor. Genç bir arkadaşımız ama gerçekten takip etmekte bile zorlanıyorsunuz. Çünkü şu anda Dubai'den Türkiye'ye gelmiş. 3 ülkeyi daha gezip bir hafta içerisinde Katar'da sempozyuma katılacak. Her yerde davetli konuşmacı olarak yer alıyor. Son derece enerjik, dinamik. Aynı gün içerisinde defalarca mailleşebiliyorsunuz. Yani gönderdiğiniz bir maille ilgili çok sayıda içinde görev vesaire olan bir liste geliyor. Onları yaptığınızda tekrar yapıyor. Gerçekten çok enerjik, dinamik. Şu anda çok sayıda textbook'ta chapter yazarı, kitap yazarı olarak akademik yayınlarda son derece yine aktif bir arkadaş. Zaten Boston Children's'ta ben de birkaç ay ziyaret etme fırsatım oldu 4 ay kadar. O zaman rahmetli analım Tuğrul Pırnar hocamıza sormuştum. Birkaç opsiyonum vardı. Hocam dedim işte Boston Children's'tan böyle bir kabul aldım. Kısa süreliydi gerçi o. İşte şu var vesaire deyince demişti ki Boston Children's çocuk radyolojisinin kutsal mekanı demişti. Dolayısıyla böylesine çok ilginç, düzenleyici, leading bir çocuk hastanesi Boston Children's. Bizim de kendisiyle gerçekten ilk defa dün karşılaştım. Böyle yüz yüze daha doğrusu konuşma fırsatı oldu. Birbirimizi bayağı tanıyoruz, görüşüyoruz. İşte yazışıyoruz. Ama böyle bir dün akşam yemeği birlikte yeme fırsatı oldu ama kendisiyle birkaç ortak yayınımız oldu şu ana kadar. Özellikle toraks MRI ile ilgili biz bayağı erken başladık Erciyes Üniversitesi'nde. Bir arkadaşın tezi vardı pnömoni ile ilgili. Sonra Burcu'nun yine tezini birlikte yapmıştık. Onun yayını. Bunlarda da Lee gerçekten ciddi katkı sağlayarak yayınlarda ortak yazar olarak bulundu. Dolayısıyla daha fazla uzatmayın. Kendisinin bugün birkaç konuşmasını dinleyeceğiz. Zevkle dinleyeceğimizi düşünüyorum. Çok faydalanacağız. Bu nedenle katıldığı için kendisine ve hepinize teşekkür ediyorum. Daha asıl bir teşekkürü de Türkan ve Figen Hanımlara çok kısa süre içerisinde çok iyi bir iş çıkardılar. Yine Sade Konuk Eğitim Araştırma Hastanesi Başhekimi yine özellikle teşekkür ediyoruz. Kendisi bütün bu organizasyonda sponsor olarak yer aldılar. Onun için sizlerle birlikte bu arkadaşlara özellikle tebrik ve teşekkür ediyorum. Lee, please.
First of all, thank you very much for that introduction. I understood a little bit. Anyway, thank you very much for organizing committee, and I feel very fortunate to be here. So I was in Dubai and on my way to Poland, Ukraine, Lebanon, and eventually Qatar. So I had like 1 day in Istanbul. Very fortunate. So what I'm going to do today is I'm going to talk about 3 very important topics in pediatric chest imaging, which includes pediatric large airway imaging, which is my first presentation. And then I'm going to talk about something very intrinsic to pediatric imaging, that is congenital malformation. So my next presentation will be focusing on congenital lung anomalies that occur in pediatric population. And the mediastinal mass becomes also very important, how to approach and how to evaluate imaging-wise and also making the correct diagnosis. So my last presentation is going to be focusing on evaluation of non-vascular mediastinal masses in pediatric population. So before I start my presentation, I do chest imaging at Boston Children's Hospital, and I have to say probably 20 to 25% of my time I spend pediatric patient with the airway disease, so this topic is very dear to my heart. So what we're going to do is, first I have a couple of acknowledgements to make. So these are my research collaborators that I work at Boston Children's Hospital. And as we all know, when we think about large airway disease in pediatric population, they definitely present very diverse clinical presentation. And as a radiologist, we definitely make we contribute very importantly because we're the one who have to provide imaging evaluation and provide a possible diagnostic consideration. Given the limited time that I have today, I'm going to really focus on a couple of things. But first of all, when we think about large airway imaging pediatric population, I think that there has been a major revolution and also improvement for the past 2 or 3 decades. As we all know, particularly with the CT imaging, which I'm going to talk about a little bit later, imaging acquisition time became much faster and temporal and spatial resolution improved, looking at the small anatomic structure, very important in pediatric population. And now what is available is actually dynamic imaging assessment. They will provide us with functional information, which a lot of people believe that is a major key to better understanding large airway disorder that occur in pediatric population. So what we're going to do today, I think I have 45 minutes for this presentation. We're going to talk about currently available imaging modalities for assessing large airway disease in pediatric patients because I see a lot of trainees. So we're going to briefly talk about what is available. And I know we are not technologists, but when it comes to imaging large airway in children, very important for us to know how to do it so we can communicate with our technologists to provide us with optimal data set. So I'm going to spend a little time on patient preparation to perform large airway imaging. And also nowadays, with a particular CT, 2D, 3D, and now we're at the stage of the 4D imaging. And I was talking to a couple of people. You do have 320 room of the CT in some places, right? How many people working in the institution, they have a dual energy scanner? Raise your hand. Not yet? Okay. So in America nowadays, we have a dual energy scanner with a shuttle mode that can actually provide us with very helpful dynamic imaging assessments. I'm going to actually show you a little bit about what's coming to you because using the dual energy scanner is becoming really popularized in recent years. And then since we are clinicians, we're going to talk about some clinical application with the imaging technique, how we can better assess large airway disorder in children. And last 5 minutes, I'm going to talk a little bit about the future direction, where it's really going. I know here a lot of people use MRI for evaluating many disorders in children. So nowadays in America, our focus of large airway imaging is really on how we can utilize MRI, which is not associated with ionizing radiation exposure in comparison to CT imaging. So when I think about large airway imaging, I think that we are really at the crossroad. The reason is because in the past, as we all know, the focus was really on evaluating anatomy and structure. But now, the focus is a combination of both anatomic and functional information. And these are the currently available imaging modalities, 4 major ones. As you can see here, we have a fluoroscopy, we have an X-ray, we have a CT, and MRI. They do have all advantages and disadvantages. For example, when you think about fluoroscopy and X-ray, it can be done very fast, relatively cheap, widely available, but of course they are associated with ionizing radiation exposure. And no matter how much best technique that you use, detailed information, particularly 2D and 3D imaging of the entire large airway, is not really possible with fluoroscopy and X-ray. So that leads us to CT and MRI. And as we all know, CT is better in terms of the fast scanning. So a lot of times with a multi-detector CT with a higher row, sometimes we do not even need to use sedation, which is actually one of the best advantages with the CT imaging. But of course, as I mentioned to you before, it is associated with ionizing radiation exposure, which is actually very important in pediatric population. And so next, what we're going to do is we're going to talk about some imaging algorithm. When pediatric patients are presenting with a possible large airway disorder, they usually present with the symptoms. That's why they usually come to hospital. Unless there is a prenatal imaging study with airway obstruction, now we do a lot of prenatal ultrasound and MRI. So when patients are presenting with a possible large airway disorder, we do first imaging, which is actually plain radiograph for initial detection. According to the literature, up to 32% of the time, you may see something. However, a lot of times, findings on plain radiograph is non-specific or hard to tell what is actually looking at because of that. In symptomatic patients, whether you have plain radiograph positive or negative findings, you still have a recurrent symptom. And sometimes you undergo or later they may have to do post-examination study. And we have a CT and MRI under the two options for confirmation if you see something on plain radiograph and characterization, and particularly for the surgical regions, the operative assessment. And since most of the places, still CT is a workhorse for evaluating large airways,
hold it, hold it, and breathe. Yeah, let's try the other way. Blow it all the way to the bottom. Nice big breath. Go up, and blow it out to the bottom. All the way, all the way, all the way, all the way. Good. Hold it, hold it, hold it, hold it.
So we
hold it,
practice a
hold it,
couple
hold it,
times,
and breathe.
inspiration, expiration.
Good job, very
And then
good.
we do have actually CT scanner right next to where we practice. Kind of, move the patient.
Okay, Rachel, you ready? Big breath in.
And we
Good.
also
Big breath in. Hold it,
practice
hold
on
it,
the
hold it,
table,
hold
as
it,
you can
hold
see
it,
here.
hold it, hold it, hold it, hold it, hold it, hold it, hold it, hold it. Breathe out. Good.
And then we're going to do person part of it.
All right, you ready? Take a
In
nice
and
big breath
breathe
in.
out.
All the way up, and blow it out to the bottom. All the way out, all the way out. Push, push, push. Good. Hold it, hold it, hold it, hold it, hold it, hold it, hold it, hold it, hold it, hold it, hold it, and breathe. Good job.
So as you can see here, we do have someone inside the scanner room actually working with the children. So with a low multiple CT, you can still obtain very high quality inspiration, expiration CT imaging in all the children who's able to practice breathing instruction and then also follow instruction during the examination. So I'm going to talk a little bit about some CT parameters for those of you who want to use it in your institution. So if you have 8 to 64 multiple CT, then combination fast table script, we do 2D and 3D imaging, which I'm going to show you a little bit later. Anatomic coverage, we do not really scan entire chest because if you do that, increase overall radiation dose. So we typically scan the patient just below the vocal cord to 3 centimeter below level of the cornea. The initial CT evaluation, I do strongly believe that even though looking at the large airway, which doesn't really require intravenous contrast, the first time when you do it, you're not really certain what you're dealing with. Am I dealing with mediastinal vascular malformations such as vascular ventilation, compressing the large airway, or rare but do occur, I'm going to show you a little bit later, Neoplasm or something like that is an intraluminal lesion. So I do give intravenous contrast the first one to get the local and complete assessment. One factor that I really want to mention in the large airway itself is we really do not need to do full radiation dose. So one of the studies that we have done a couple of years ago, actually demonstrating the fact that expiration part of the imaging, you can actually reduce MAS down to 50%. So in that way, you can still visualize the large airway very well, but you do not need to use full 2-time radiation dose during inspiration and expiration. So in expiration part of imaging in our institution, we actually decrease the radiation dose down to 50%. So here, the one at the top is done with full radiation dose technique. The one at the bottom during expiration, we lower the radiation dose down to 50%. But looking at the airway caliber, because airfill lumen and enough soft tissue within the mediastinum, you still can see the caliber changes of the trachea because you do not need to use full radiation dose. We're going to talk about some dynamic imaging. As we all know, that's when we actually have 3D imaging model with real-time assessment. Unfortunately, my video clip is not working here. I just wanted to mention about the fact that if you have a 300 neural multiple CT, we real-time scan the patient, usually 5 to 8 seconds, continuous scan, and then we actually look at the patient during the real time. So you can see airway collapse during dynamic phase imaging, which can be very helpful for us to evaluate underlying tracheobronchial malacia and differentiate with a fixed defect, which is actually stenosis or narrowing. And this is actually something new. We have a dual energy scanner. That one has actually only 96 volt, but what we do is actually the shuttle mode. So practically, I wanted to show you here. We have a patient on the table. Patients are going back and forth. I have a little phantom here. And then as you can see, during the real time, we can actually obtain the dynamic phase of the imaging, and we evaluate that in the cine mode, which I'm going to show you a little bit later. So once we obtain axial CT data set, of course, the post-processing technique becomes particularly important in pediatric imaging when you look at the large airway. So once we obtain axial CT data set, we reconstruct the images multiplanar, and the maximum and minimum images, and also volume rendering. Starting with the multiplanar, as we all know, we use it all the time. We don't have to spend time doing this because our CT technologists usually create those and send it to our PAC system. But when it comes to airway imaging, trachea is never straight down. Because of that, when you perform coronal and the sagittal imaging, you don't really capture the entire trachea. Because of that, very important to spend a little time in doing some curved multiplanar imaging. So here, as you can see, following the mid portion of the trachea very closely and centered around the trachea, the sagittal multiplanar images, you can actually create curved coronal images. So that would give actually very precise evaluation of the airway, particularly if you have to measure the degree of the airway collapse or narrowing before surgery. So here, 16-year-old girl presenting with progressively worsening respiratory distress. Had a motor vehicle accident 6 months ago with a 2-month hospitalization, the intubation. So here, as you can see, the mid portion of the trachea, very high-grade narrowing due to endotracheal tube placement, causing. What about 3D volume rendering? It's getting a lot of attention for the past decade because it gives you kind of real-time assessment. So unlike regular 2D imaging, when you create the 3D imaging, entire data set is actually incorporated into the image reconstruction. It gives you a global assessment and it doesn't really lose any information. So this I find it very interesting. So this scan was actually nicely done at outside hospital. And then the outside hospital, radiologists thought that there is a distal tracheal narrowing or congenital stenosis. Because of that, patient was referred to our hospital for surgical operation. And the surgeon kind of wanted to see 3D imaging because we do that all the time in our institution. So with the same data set from outside hospital, we just recreated 3D imaging. And the interesting thing is that instead of just having the narrowing in distal portion of the trachea, carina and proximal mains and bronchi is actually also narrowed. With that additional information, now surgeons need to know that not only they have to repair the distal trachea, they have to reconstruct the entire carina. Because of that, it's additional surgeon with 3 more hours of the repair surgery. So it really changes patient management and it really helps communicating with the referring physician, surgeon in this case. So a lot of people ask us questions. So when do we do post-processing and when it is helpful for evaluating large airway and pediatric population? When it comes to subtle stenosis, as you can see here, our eyes, if you look at something just scrolling up and down, you may miss those subtle stenosis on individual axis. So when you look at through the imaging, that subtle narrowing irregularity of the airway can be clearly visualized and nobody's going to miss that because it doesn't look like the normal trachea. And then also evaluating longitudinal extension in patients with a vascular ring with a tracheal compression and looking at the relationship between airway and adjacent media kind of structure, vascular structure, and then also soft tissue structure. Really through the imaging becomes particularly helpful. So how many people here know how to use 3D workstation? Raise your hand. Okay, so some people. So I'm going to ask anyone who doesn't really know how to use it, why you are not using 3D workstation when you do actually look at the airway? It takes a long time. We're just so busy in the reading room, right? And then we have to read fracture follow-up, bone ages, that painful skeletal survey. So when do we have a time to actually reconstruct? So I do really have to say the fact that the post-processing, not the vessel or osseous structure, when it comes to airway imaging, it's just really simple. This is kind of prototype 3D monitor workstation. It has a preset, as you can see here. You just click on the preset, airway imaging, and then you can look at it from the sagittal and coronal. And I like the trim function. So as you can see here, I'm kind of trimming anterior and posteriorly, and then up and down, and then right to left side. And a lot of people here are young, so you can look at these images, but when you become older like me, you want to look at images big, so I kind of magnify to look at what's abnormal. So when you actually look at this, the entire thing, it just takes less than 9 seconds. So to be very honest with you, even very busy clinical setting, you can just quickly do this to look at the large airway instead of just relying on your CT technologies for just multiplanar 2D imaging. So I just want to emphasize the fact that you will find a lot of subtle things when you actually start doing this 3D imaging. And as you can see here, it really doesn't take a long time and doesn't really require a lot of skill. If you know how to play video game, you can do this. So since we talked about imaging technique and imaging algorithm, so next 30 minutes we're going to talk about some clinical application. So when it comes to pediatric imaging, definitely we need to talk about some congenital malformation. It could be non-vascular lesions such as tracheobronchial anomalies, or it could be some vascular lesions compressing the airway extrinsically, or sometimes they may associate it with intrinsic airway abnormalities such as malacia related to vascular ring and sling. And neoplasm, rare but do occur in pediatric populations, so we're going to look at a couple important ones. It could be primary large airway tumors, or it could be secondary lesions coming from outside, invading or compressing. Of course, particularly this part of the work, infection do occur, so we're going to look at a couple of infection. And at the end, we're going to look at some dynamic large airway evaluation. What we do here is looking at underlying tracheomalacia, that's intrinsic abnormality, and comparing and also distinguishing between fixed defect, which is actually stenosis or stricture. We're going to start with some non-vascular congenital malformation, of course. Tracheobronchial malformation, ectopia becomes very important, so we kind of have to recognize them. So here in patient presenting with recurrent right upper lobe pneumonia, because of that, we actually performed CT imaging, and the other patient was asymptomatic. Patient was actually, we're looking for possible underlying sequestration. Patient did not have a sequestration, but we saw some airway malformation. So here, anomalous right upper lobe bronchi directly arising from trachea with tracheal bronchus. To be honest with you, something like this. I don't think that you need to do 2D and 3D imaging to make the correct diagnosis. I think the axial CT data set is just sufficient enough and usually correlate very well with bronchoscopy images. Here, ectopic bronchi arising from trachea, consistent with what we see on CT imaging. But a lot of times, particularly those patients with congenital multiple malformation, their abnormality is actually not really that simple. So looking at 2D imaging and 3D imaging becomes very helpful. So here in this patient with a large tracheomalacia, so here, as you can see here, the patient definitely has a large tracheal bronchus, but the patient was asymptomatic. Because of that, we did the 3D imaging, and not only having actually large tracheal bronchi, the patient also has stenosis involving trachea just above the corona. So you can look at very complex anatomic structure with a 3D volume rendering, or you can actually look at virtual bronchoscopy going down, down, down, to actually the area of the narrowing. And then here we can come back and then look at also the tracheal, the area of the ectopic bronchi. So here, as you can see, without rescanning the patient with a virtual bronchoscopy and then volume rendering, we can look at the airway from outside and inside. And this patient did not require bronchoscopy after CT imaging because you practically have all the information that you need. Next, we're going to move on to some congenital stenosis. That's a tracheobronchial stenosis. Primary one is rare. Affected patient typically present very early in life. And then the reason is because they do have underlying absent tracheal membrane or deficient tracheal membrane. Here, 90% of the time, they present actually first year of life with typical clinical presentation, which is a 5-page spider. Also want to look for other congenital malformation, which is tracheal bronchus, also pulmonary artery stain. Here in this patient with tracheal stenosis, involving with a very hypoplastic pulmonary artery stain. So this patient unfortunately had both of them. And degree and narrowing and then also length becomes particularly important. Less than 6 vascular ring, tracheal ring. Those are the short segments, so affected patient may undergo primary surgical resection of those tiny ring, and then get primary stenosis or anastomosis. But if the patient has a long segment tracheal stenosis, those patients will need to go tracheal reconstruction or tracheoplasty instead of primary resection and putting them together surgically. And I do believe the fact that the practice pattern in our institution changed substantially, meaning the fact that 15 years ago, a patient underwent bronchoscopy much more frequently. Now, we do use bronchoscopy for treatment usually, but we do CT imaging before bronchoscopy. So if you don't see anything on CT imaging, those patients usually not undergo bronchoscopy. And sometimes if you perform bronchoscopy before, a lot of times they may also request CT imaging afterwards because they really could not completely assess the large airway. So this is a good example. So we got a call from the pulmonologist who was actually performing bronchoscopy, and then her question was, well, we were able to look at the upper airway, but as we placing down the scope, we just couldn't pass our scope down. And we just don't want to blindly push it down because we just have no idea what's behind it. The patient was just sedated at the time for bronchoscopy procedure. So we just quickly moved the patient to our CT scanner. We scanned the patient, and no wonder why they were not able to advance the scope. So there's a tight, very tight stenosis involving the distal trachea. Because of that, they advanced the scope. So we did the CT imaging, and as you can see, behind the carina and main stem bronchi is actually patent. And with the virtual bronchoscopy, we were able to actually, pass down and see what is behind the narrow segment, and then behind the carina and bilateral main stem bronchi is patent. So it gives you actually complementary information, even in some patient who's not fully successful with the bronchoscopy because of the stenosis, and they really cannot visualize the airway. And that's their question. It's just the top part involved when any of the distal stenosis and extension is involving. Another case with actually bronchial stenosis. This was actually an interesting case where the patient was presenting with progressively worsening respiratory distress. And one of our radiologists, who's actually musculoskeletal radiologist, we have a 54 pediatric radiologists. So we are somewhat specialized, but we do cover everything. But it just happened that she was covering very busy service on Friday. She had to go to New York to see her daughter. So she just, quickly looked at 3D bound rendered images from outside. And then she thought that, well, there's irregularity involving the right main stem bronchi, but looks kind of patent in terms of the caliber. And the left side is definitely normal looking. And then she just finalized a report and took the train to go to New York, and the pulmonologist thought that was kind of odd because the patient was definitely symptomatic. And then we actually performed virtual bronchoscopy with the same data set, and we kind of notified her. So as you can see, most of the abnormality or obstruction is actually internal part of it rather than outside. So I just want to emphasize the fact that very important. Actually look at from inside and outside when you evaluate the large airway. And now it's possible with processing. Since we talked about some non-vascular lesions, we're going to quickly move on to some vascular rings and things. That's bread and butter pediatric imaging. I don't know whether you guys take oral board here. Do you still take oral board? In America, we eliminated oral board, and then now we have multiple choice questions. But still, we test vascular rings all the time. Very bread and butter pediatric imaging. So here, starting with the double aortic arch, as we can see here, the right side and left side aortic arch coming from ascending area, they join together. And in the middle of it, there's a trachea, and then also esophagus, and then patient can have a symptom. Here, after CT narrative, nicely demonstrating complete vascular ring, really bound and images, looking from behind it. The right side arch is higher, and the left side arch is kind of smaller than more. And aortic compression, looking outside, from inside, and it's really visualized. We do pre-operative and then post-operative assessment, particularly those patients, even after surgical opening of the vascular ring, if they're symptomatic, we do CT, looking for not the vascular part only, but also the like airway problem. So this was a great case. Patient preoperatively complete vascular ring. So looking from behind, the left side was actually smaller and then lower. Because of that, the vascular surgeon went in and opened up. However, patient was asymptomatic, so we repeated the imaging. And I see demonstrating during inspiration and expiration, there's a complete collapse down of the trachea, tracheal malacia associated with a vascular ring. So this patient had to actually undergo airway repair. One of the things that I want to emphasize is a couple years ago we looked at the patient with vascular rings and sling, and then if they are having persistent symptom, meaning that after opening up vascular surgery, if patients are still symptomatic, a substantial portion of those patients will have underlying tracheal malacia. For example, we found that a high association with inner artery compression syndrome even after surgery, because it's anteriorly compressing, so those tracheal ring, that cartilage is actually damaged substantially. Because of that, they have a high percentage of having underlying symptom even after surgery, which is followed by the aortic arch and the right arch with abdominal left artery in that order. So if someone is symptomatic even after the surgery, not only think about, well, vascular resection surgery is not done well, but also maybe intrinsic gynecological problems such as moving on to another admit in radiology, which is actually pulmonary artery sling. In this condition, as we all know, left pulmonary arteries arising from proximal right main pulmonary artery embryologically is due to agenesis or obliteration of primitive left 6 aortic arch. So that portion constitutes proximal portion of main pulmonary artery. So our body is very smart. We find a way to get the blood supply. So embryologically, if that portion is missing in the left lung, we recruit somehow the vascular structure from right side, supply the blood supply on the left side. So that's why the vascular ring of pulmonary artery sling is occurring. I'm sure a lot of you heard about type 1 pulmonary artery sling. That's a more common type. In this condition, corona is normally located at T4 to T5 level, and they do have very characteristic compression. And we test this all the time in American Board of Radiology. As you can see here, there's a characteristic compression in the posterior aspect of the trachea. And then they do have sometimes anterior aspect of the esophagus and main stem bronchus. Because of that, affected patient may present with respiratory symptoms. So how many people heard about type 2 pulmonary artery sling? A couple people. So this type 2 pulmonary artery sling is much more rare than type 1 pulmonary artery sling. But this is the one that radiologists will get into trouble. I do some medical legal work, and I can kind of tell you, a lot of times we get very excited as a radiologist. Oh, we found the reason why patient is having respiratory distress. There's a pulmonary artery sling. I love this case. And we do not really pay close attention to large airway. And then a patient undergo just reimplantation of the pulmonary artery. And then a patient may have a persistent symptom. And later they recognize not only they have a problem with pulmonary artery as a pulmonary artery sling, they may also have underlying long segment tracheal stenosis, which is associated with type 2 pulmonary artery sling. So very important to look at underlying vascular ring, and then also underlying large airway malformation associated with vascular anomaly. The way that the corona look like on type 2 pulmonary artery sling, because corona is low in location at T6 level, because of that, almost like inverted T. So I'm sure some of you heard about a T-shaped corona that's referring to with the pulmonary artery sling. So this patient was very unfortunate. Here, the patient had a type 2 pulmonary artery sling during inspiration. Of course, there's actually a very high-grade long segment tracheal and then also bronchial stenosis with compression. And during inspiration and expiration, also have a complete bronchial malacia. Here, very difficult to manage the patient because they actually reconstruct entire large airway. Since we talked about some congenital malformation, we're going to move on to other exciting topic, which is actually pediatric large airway neoplasm. As I mentioned to you before, much more rare in pediatric population than adult, but do occur. So we need to pay very close attention. We're going to start with the three important key points. First of all, rare. Second, usually benign, which is a good news, and typically occur in the upper 1/3 of the trachea. So that's the reason area that we need to pay close attention. So for example, this is actually a young infant presenting with respiratory distress. We did a CT imaging. We saw some vascular lesion, and multiple images are very highly vascular in the subglottic region. And then pulmonologist sent me corresponding bronchoscopy. Most common subglottic airway primary neoplasm that occur in infant typically present with respiratory distress, which can be biphasic. Anyone can tell me what this could be? Start with H. That's not very good. So subglottic hemangioma. So this is one of the most common vast primary neoplasm that occur in infant. What about this one? So a little bit older. So a patient was presenting with horse neck, and we did soft tissue neck, and we saw some intraluminal soft tissue density. So we performed the CT, another definitely intraluminal, and up to 5 to 10% of the time, they have a multiple lung lesions. Some of them are nodular, some of them are cavitary. Anyone can tell me what? Excellent, very good. So this one actually a tracheal papillomatosis. What about this one? Also a little bit older, typically occurring in the proximal or mid-nasal bronchi. Here, right side is more commonly involved than left side. Also intraluminal, heterogeneously enhancing, and also very vascular. And hopefully your best friend is a pathologist. Actually, my best friend at Boston Children's Hospital is a pathologist. So she always tells me when I'm wrong. Sometimes send me a free pathological slide for my presentation, which is great. So this is a synaptotrypsin stain, which actually highlights the underlying neuroendocrine cell. The most common malignant primary large area neoplasm that occur in pediatric population start with C. Anyone can tell me what this could be? Anybody? Excellent, very good. So carcinoid tumor. So these are the three most common primary large area neoplasm that occur in pediatric population, including subglottic hemangioma, tracheal papillomatosis, and also carcinoid tumor. And of course, not only primary tumors, but the secondary neoplasm that occur. It could be extrinsic compression, for example, Hodgkin's lymphoma, compressing the airway from outside. Or it could be metastatic disease, very unfortunate child, prostate rhabdomyosarcoma, which was resected 10 years ago. And the patient was having chest pain with a short sense of red. So we obtained chest plain radiograph followed by the CT. Very heterogeneous mass in the mediastinum, and which was biopsied, and late onset recurrence of actually rhabdomyosarcoma from prostate presenting as a intestinal adenopathy. Very unfortunate child, and patient fortunately very well. We're going to move on to couple infectious etiology, for example, TB. Very relevant here, right? We still see that a lot here in Turkey. In America, we don't see that much, but whenever I travel, particularly South America and in Asia, there are a lot of TB infection, twin bud, lung lesions, as you can see here, sometimes consolidation. In pediatric population, primary TB usually presenting with a lymphadenopathy, extrinsic compression, as you can see here. But whenever you see some irregularity of the large airway, advanced disease, not only they are associated with just the compression, they may have erosion in the large airway. So we need to pay very close attention. And once you involve in the large airway, extension and involvement, very hard to manage and treat. They may have a post-treatment stenosis and recurrence. Next, we're going to move on from static to some functional large area imaging. As I mentioned to you before, this is what we are evaluating underlying tracheobronchial malacia and also trying to differentiate from fixed defect, which is actually stenosis and stricture. Before we get there, I'm going to talk a little bit about some underlying pathophysiology associated with tracheobronchial malacia. So as we all know, unfortunately, when I think about tracheobronchial malacia, it's kind of tip of iceberg lesion. The reason is because I think that still, because we don't really perform dedicated exploration images, But tracheal malacia can only detect during expiration. That's when the large airway is actually collapsing down. A lot of cases are still missed. One of the most common clinical presentation that I hear that raise the possibility is actually atypical asthma. The pulmonologist comes to you and then say, well, I think that my patient has asthma. They have a shortness of breath and they get some infection. But you know what? The patient is not responding to typical asthma medication. Should have a high clinical suspicion for possible underlying tracheal malacia because a lot of patients are mistaken as having asthma. So once again, I do believe that this is kind of underdiagnosed condition. The reason is because most of the imaging study that we do, we ask patient to take a deep breath in and hold, and that's when we scan. So unless you provide dedicated expiration imaging, very hard to detect an underdiagnosed condition. So as we all know, the change in size of the malaysic trachea and bronchi really depends on the difference between the intraluminal pressure inside the airway and pleural pressure outside. So that changes, actually changing the caliber of the large airway. So for example, when you have at the end inspiration, that's when we have a maximum lung volume. So intraluminal pressure inside the trachea is actually greater than pleural pressure. Because of that expand trachea. So when it comes to end expiration, that's when you have a low lung volume. Intraluminal pressure equalizes extraluminal pressure. Because of that compresses trachea. So for example, in our institution, when you don't have a high-low multi-test CT looking at 4D imaging, you can actually ask older patient to cough. That will increase the intrathoracic pressure. So ask them to actually cough, and when you do that increase in intrathoracic pressures and that captures tracheal bronchomalacia much better with a higher sensitivity and diagnostic capability. So that's some of the things that we do in our institution, which I'll show you a little bit later. In CT criteria, for example, tracheal malacia is very important in terms of how we make the diagnosis. In pediatric population, we still go by 50%. That data came from the bronchoscopy data, demonstrating the fact that if they were more than 50% of the tracheal compression, probably those patients had underlying tracheal malacia. A couple years ago, the adult radiologist, probably the most famous adult chest radiologist, Dr. Bill Boisel, from the editor of Journal of Thoracic Imaging. So his NIH grant study demonstrated the fact that in adult population, so he recruited healthy adult patient and he scanned the patient during inspiration and expiration with the CT, and he found that more than 50% of the trachea can be compressed up to 60% in normal adult patient. And when you actually sometimes from the fluoroscopy in normal patient, you do see tracheal compression more than 50% in young infant and children. Unfortunately, we cannot do the same type of prospective CT imaging study in healthy children because of the radiation dose effect. But I do believe the fact that probably between 70 to 50% of airway collapse, it could be still normal, but you probably need to collaborate or correlate with clinical presentation, and then also the bronchoscopy or pulmonary function test result to make the diagnosis. But no matter what, if you have a criteria of more than 50%, you will capture most of the moderate to severe tracheal bronchomalacia. So that's a criteria that we use in our institution. So a couple of examples here, a young child presenting with respiratory distress. We did an end inspiration and expiration. There's irregularity in the trachea. However, there's no caliber changes. So this patient had a tracheal stricture narrowing. What about this patient? This patient was a 12-year-old girl with more than 15 CT studies from 4 different hospitals. They went from America, so if you remember, Great Ormond Street, Children's Hospital, Philadelphia, and Toronto. So multiple great hospitals performed CT imaging, and they all said normal with lung infection with the bronchiectatic changes. Came to our hospital. Our pulmonologist raised the possibility of underlying tracheal malacia, and so we did the inspiration and expiration low dose technique. The patient has a severe tracheal malacia involving the mid portion of the lung. Unfortunately, lung is damaged already with a multiple recurrent, probably the aspiration, often related with underlying tracheomalacia. So this one I see demonstrating underlying tracheomalacia. As I mentioned to before, if you don't have a higher multiplicity, even though you have, for example, 64 multiplicity, it gives you a 4 centimeter G-axis coverages. Older patient, yes, actually patient to cough, cough, cough. So patients are coughing and posterior wall of the trachea is actually compressing, but not entire trachea is actually compressing down. But when it comes to tracheomalacia, as you can see here, entire airway is actually collapsing. So you can make the diagnosis and coughing method with the Emphysema images. And the way that the trachea collapses, some people believe that they look very similar to almost like a frown face. So because of that, the name of the frown face came up. So kind of new sign in radiology. And when you actually look at chest CT, particularly pediatric patients, they don't really follow pre instruction. So a lot of times studies are done during mid exploration or even exploration, and you will find some of the patients do have actually tracheomalacia, but you may not look for it unless you take to a large airway. So given the limited time, next 5 minutes, we want to talk a little bit about where are we going in terms of the large airway imaging in pediatric population. Once again, I think that 4D imaging is getting a lot of attention with the dual energy scanner with the shutter mode. And as we know, a lot of institutions now they have a 320 room multiplicity, low dose technique, and dynamic imaging without sedation. All very important in pediatric imaging. And of course, nowadays, utilizing MRI recognition, we believe that most of the things that we can do with the CT imaging, if you optimize with the scanner that you have here, you should be able to get most of the important information, which some we should review later. In the past, we waited until babies are born, and if they are symptomatic, we try to manage it. But in America, particularly, what's really happening is we're paying more attention to prenatal imaging. Up to 97 to 98% of the female pregnant women in America in the big city, they are getting at least one ultrasound, a prenatal ultrasound. And if they see abnormality, for example in Boston, up to 85 to 90% of the time, as long as the insurance is covering with the prenatal MRI. So we can detect a lot of airway problems prenatally. And of course, one of the hot area in surgical, any of the pediatric surgeon here, is actually prenatal surgery or in utero surgery to see whether we can actually save any of those fetus who may be the demise if you leave them alone. So we're going to start with the 4D imaging. Unfortunately, my video clip does not work, but whenever we think about the 4D imaging, people always asking the question, what is a 4D imaging? So practically 4D imaging is a combination of very exquisite, nice detail of the 3D with a real-time assessment. Some people believe that real-time assessment is actually another dimension. So for example, tracheomalacia, looking at the cross-sectional imaging, so looking at 3D imaging and 4D imaging becomes much more easy to appreciate the degree of the narrowing and collapse, and also extension becomes important. Here in this patient, the tracheomalacia is involving just intrathoracic portion of the trachea, but the upper portion of the airway is actually patent. Much easier to manage rather than someone who's having trachea collapsing down. One of the things that we have done a couple years ago is a little bit interesting because of this history. Because 10 years ago, adult population, they had a publication nicely demonstrating those patients with underlying tracheomalacia, they do have underlying small airway problem. The reason is because they do get return aspiration that leads us to underlying small airway association and a small airway problem. So they attributed large airway problem to small airway problem, which is actually acquired disorder. And what happened was affected. We're looking at more infant and young children with tracheomalacia. We also found that substantial portion of those patients, even though they didn't have a time to aspirate, those patients also have underlying small airway disease characterized with the air trapping. So now we are postulating those patients with large airway weakness it's not just causing as a aspiration, small airway problem, but that intrinsically they also have a small airway weakness. So here that's correlation between someone who has a tracheomalacia with a multiple air trapping, and these were infant who didn't really have a time to aspirate. So definitely congenital in nature. The second part, as I mentioned to you before, is actually moving toward MRI imaging instead of from the CT imaging. So now what we do is actually, even we have a spirometer controlled cine MRI evaluation. Out of this spirometer, for example, the problem with MRI has to be the fact that we really don't know when we are imaging the patient. But here, this spirometer is all MRI compatible. We practically replace all this metallic portion with the plastic. So we actually integrate the patient, and during the real time, connect to the computer, we know exactly, almost using the pulmonary function test, we know exactly at what part of the respiratory cycle we are actually evaluating. And in terms of where we are now of the large area imaging with MRI, so here on CT and MRI during inspiration and expiration, give you very similar imaging diagnostic information. And also moving forward to some small area bronchial changes. If it's a moderate and severe degree, not the subtle one, there's no reason for you to do actually CT, because MRI with a high optimized imaging technique will give you enough information. Here we do some dynamic imaging twist technique that we do looking at the large airway. And the one thing that I really want to actually emphasize is that when you looking at the MRI imaging, when you window them, you can also see some small airway problem with air trapping that you see on CT. So here in this patient with MRI, definitely they have underlying tracheomalacia. So with the CT, we can get with MRI. We can do some volumetric information once we obtain the large airway. And one of the study that we done recently, there's a very high correlation with MRI with the inspiration expression technique in comparison bronchoscopy. So I really believe the fact that if it's available and even if the longer time preparation, I can be definitely simulation data population. And once we have Excel data set, just like what we do with within 3D imaging, looking at the airway collapse here. I don't know how much MRI is performed in your institution. So last year we actually came up with a very practical imaging protocol. So which can be done in actually 20 to 30 minutes. So after localizer, and then we do some true fist images, looking at later with the four-year transformation technique. We look at some ventilation and perfusion, and we perform couple gradient echo sequence during inspiration and expiration, looking at the large area structure, and then motion correction technique, play sequence that we use in our institution, can be very, very actually helpful for looking at the lung parenchyma, such as the bronchial changes. As you can see here, this can be all done in 30 minutes. So even very busy clinical practice definitely is something that you can do with MRI. And I don't want to spend a lot of time here, but I just want to show you. I know there are some institutions, they do have a hyperpolarized helium gas imaging. So in the past, we've been using it for just looking at the lung parenchyma, as we all know. But the early part of the inspiration of those hyperpolarized helium gas, you're actually looking at the airway structure, not only just looking at the lung parenchyma. So if you have the capability, definitely that's something that you can use with the large airway. And lastly, as I mentioned to you before, now we're focusing on more prenatal imaging rather than just the postnatal imaging. So for example, in this patient, prenatal MRI reconstruction of the large airway and soft tissue, large teratoma, actually expressing large airway. Second trimester, if you leave it alone, in utero demise, such a danger to pregnant woman. But once actually recognizes abnormality, and do prenatal surgical resection, preventing utero demise, and also it could be very potentially life-saving for pregnant woman. So focus is definitely not only just MRI postnatally, but also prenatally. So given the limited time that I had today, we went over some large airway disorders that occur in pediatric population. A couple take-home points that I want to leave with you. definitely a variety of the disorder and clinical presentation. But if you kind of think about, am I dealing with congenital malformation, infection or neoplasm? Once you do that, and then think about, am I dealing with some static airway problem or dynamic airway problem? And appropriately protocol the imaging study tailored to individual pediatric patient, you can obtain studies. Right now, in terms of the direction, we are at the stage of 3D2, quickly shifting over 4D airway imaging, particularly with the CT and MR, and then dynamic was, anatomic evaluation was what we focused in the past, but now more functional imaging in combination with the anatomic structure evaluation is becoming important. And as I mentioned to you before, most of the study, I truly believe that we are now doing with the CT and now do with MRI. And I just wanted to mention that understanding patient preparation, particularly in children, using optimal imaging technique and understanding some characteristic imaging findings, we can all do it and make the correct diagnosis for proper patient care. Thank you very much for your attention. Do you have a time for question, or should I just go into my next talk?
Devam edelim. Edelim değil mi?
Sure. Right. Okay, so we're going to move on to the next topic, which is becoming true pediatric imaging technique, bread and butter pediatric imaging, which is actually congenital malformation. I do believe that even though as a pediatric radiologist, we are aware of congenital malformation, still it gives us a puzzling imaging findings sometimes, so very important to understand. And also there's some upgrade classification system. So today I'd like to introduce you to some upgraded system. So given the limited time, what we're going to do is, first we need to know how to manage this patient. So we're going to talk about imaging algorithm. And then once again, we're going to talk a little bit about imaging technique, because we are looking at the long parenchyma, and most of the studies are actually done with the CT imaging. So we're going to talk about some multi-detector CT parameter, and then some post-processing technique. And then I'm going to give you some information regarding upgrade review of or updated review of congenital malformation. Some of them has new classification system, so I'm going to show you. And in order to understand imaging findings when it comes to congenital malformation, very important to kind of understand underlying pathology, which becomes very helpful. So I'm going to do some red hat correlation in selected cases, which I think they will be very best evaluated with the underlying pathology and imaging study. So we're going to start with some imaging algorithm. The way that we evaluate the congenital malformation substantially changed for the past decade. The reason is because now we do so much prenatal ultrasound and fetal imaging. For example, in the past, we waited until babies are born. And if there was symptom, usually respiratory symptom, we image the patient and we try to make the diagnosis. Nowadays, I don't know how much prenatal imaging are done here. Are there a lot of prenatal imaging are done? Great. So as a radiologist, we get a requisition. They know already focal lung lesion from prenatal ultrasound and MRI. And our job is characterizing them. So in a way, it got a little bit easier because we know exactly what we need to do, but at the same time, it became a little bit more complicated because surgical management changed substantially. So I'm going to tell you a little bit about that. And as a radiologist, we need to give you much more information. Just saying pulmonary sequestration is not sufficient enough. To tell them what it is, to characterize what the vessel job, we need to actually recommend what could be the proper and optimal surgical management, which I'm going to show you a little bit later with the case presentation. So once we obtain actually prenatal ultrasound and MRI, and we know there's a focal lesions, or some patient may not know, but they have a respiratory symptom, or older patient, they may present with the symptoms such as infection. We do a chest radiograph. In the past, some people, for example, pulmonary sequestration in infant and young children, sometimes they try to do with ultrasound, but that's kind of outdated. We don't do ultrasound for evaluating abnormal vessels anymore. So after playing radiograph for initial detection, particularly if you see something, we do cross-sectional imaging studies such as MRI and CT for confirmation, characterization, and pre-op evaluation. Once again, I do not want to spend a lot of time what imaging modality, almost like comparing apple to orange, what is better. I think that MRI and CT, they provide almost complementary to each other. They're providing different information, similar information with a different imaging technique. But I do have to say the fact that when it comes to evaluating underlying lung parenchyma, even though MRI is very, very advanced, first study, you probably still need to do low dose CT to complete assessment of the lung parenchyma. Because of that reason, we actually perform CT imaging. Sedation, as I mentioned to you before, if you don't have a higher low multitude CT, which does not require sedation, you may have to sedate them. Oral chlorohydrate, IV phenobarbital, you need to closely monitor to make sure those patients are safe. Just a basic MRI CT protocol in combination test table speed. Two factor that determines overall radiation dose is MS and KBP as low as possible. For example, in our institution, we actually look at the age and weight of the patient, just MAA and KBP. Once again, substantial portion of congenital malformation, they do have associated vascular malformation. Because of that, we do give intravenous contrast for the first study to make sure we completely assess. And 2D and 3D imaging and 4D imaging sometimes becomes important. So once you obtain XSTT data set, we do corner and sagittal reconstruction. And then if you want to look at the vascular structure, we look at the vessel and also large airway. But the question that we have to ask ourselves is, as a radiologist, why did we go into radiology? Anyone can just tell me why you went to radiology? Okay, my favorite person in Turkish radiologist, Suraya. So why did you go into radiology? Making a lot of money in Turkey, right? No, just kidding. No, like, why did you pick radiology as your sub? Yes. Aspect of it? Okay, great. Compared to other, like a specialty, like you're very interested in advancing technique? Got you. Any trainees here? First year training? Who? Any radiology resident? Sitting? Raise your hand. Don't be shy. Okay. So when there's a visiting professor, like they have no idea their names, right? So they always ask the question to who is the chief resident? Do you guys have a chief resident? So raise your hand. Chief resident. Don't be shy. Who's the chief resident? Did he show up today? He should not be chief resident. I'm just kidding. So I'm going to ask fourth year resident. Who's the fourth year resident? Raise your hand. Don't be shy. Okay, so why did you go into radiology? Be honest with us. Okay, excellent. I mean, don't you think you were so honest? So another most frequently actually, the answer is actually, a lot of people say they are very visual. Am I right? So like they like to look at things. They like to look at pretty things and they want to make the diagnosis based on what they see. Raise your hand, that's why you went to radiology. I think a lot of people went into radiology because they are very visual people. And who does not want to look at the pretty things, right? As a radiologist. But I really think that unless something provides additional information and increase the diagnostic capability and confidence level, doing this post-processing takes time and resources and energy, and someone needs to pay for that, right? So it does not really need any additional value. So one of the questions that I always have is the fact that does this 2D and 3D imaging, or nowadays we do 4D imaging, we talked about airway imaging with looking at things dynamically. I do believe that that adds value because you miss a lot just looking at the XSCT data set when you look at the large airway, which is dynamic digital process. What about when it comes to congenital malformation? Because of that, a couple of years ago, we actually looked at 46 children with pathologically proven congenital malformation. And what we did was actually we compared axial CT data set compared to multiplanar and 3D imaging. Does 2D imaging and 3D imaging add any diagnostic value? And what we found is, I think it's very interesting. So when you make a diagnosis and localizing them and measuring the size, 2D and 3D imaging does not really add any value. We can still make the diagnosis of the focal lung lesion. However, when it comes to evaluating vascular components of malformation, particularly small veins, in comparison to artery, 2D and 3D imaging, particularly infant and young children, add diagnostic value. And this becomes very important nowadays because in the past, surgeons did entire thoracotomy. They opened up, looking at the congenital malformation, and they were able to visualize mass and then also take out all those vessels. But nowadays, they do minimum invasive procedure. They put the two trocar, deflate the lung, looking at the video scope on the monitor, and then try to dissect those things out. So we need to provide more precise information when it comes to vascular components of it. And there were some cases where, as I mentioned to you before, I did some medical legal work where the pediatric radiologist didn't really recognize those abnormal vessels, and the surgeon just went in and didn't think that there was more than one vessel, and they just yank it out. And then what happens is there's a hemorrhage, and then it becomes emergency thoracotomy, and a lot of times bleeding already, and then finding those vessels becomes particularly difficult. But anyway, so because of 2D and 3D imaging, that vascular component evaluation added diagnostic value and confidence level particularly. When we make the diagnosis in our institution, we do routinely perform 2D and 3D imaging when we evaluate congenital malformation. So since we talked about imaging algorithm and imaging technique, next we're going to talk about congenital malformation. Just like any congenital malformation that occur in other body part, when it comes to lung malformation, it is within the spectrum. For example, at one end, there's a normal vasculature, but those are the abnormal parenchymal lesions. CPAM, which we'll talk about a little bit later, is a great example. They do not have abnormal vascular components typically, but they do have lung parenchymal abnormality. And then other spectrum, within the spectrum, it's abnormal lung with a normal vasculature. For example, unless there's a complication, bleeding or infection, such as pulmonary AVM, those are the pure vascular lesions, but they do not have underlying lung parenchymal abnormality. And of course, life is not always that simple. And some of the lesions, such as the sequestration and scimitar syndrome, they do have abnormal vascular components and then also abnormal lung parenchyma. So we're going to start with the first category, which is actually underneath the abnormal lung with a normal vasculature. In this section, we do have four very important topics, which is the bronchogenic cyst, congenital emphysema, CCAM, that is old name, now it changed to CPAM. So that's upgrade. I'm going to talk a little bit about why we did upgrading with the classification system and how academic radiologists become famous again, not doing anything. So I'm going to tell a little bit about what happened with the new classification system. And we're going to talk about bronchial atresia. So we're going to start with the bronchogenic cyst. As we all know, this occurs very early in life, between 26 to 40 days of the gestation, and part of the foregut duplication cyst. So in the past, in radiology and textbook, we tried to actually distinguish between bronchogenic cyst, esophageal duplication cyst, and urinary cyst. And how do we make the diagnosis? The definitive diagnosis is usually pathology. So I always thought that bronchogenic cyst, you see respiratory epithelium. And esophageal duplication cyst, you see esophageal or GI mucosa. And if you see some neural components to it, probably you're dealing with urinary cyst. The thing is that even in pathology, that is not that straightforward. If you have lesion with substantial portion, more than 50 or 60% respiratory epithelium, they typically call bronchogenic cyst, but they do also have some GI mucosa. So even in pathological literature, now in radiology, instead of trying to distinguish whether you're dealing with bronchogenic cyst, esophageal duplication cyst, or urinary cyst, we like to kind of put them under the big umbrella term, which is a focal duplication cyst. And we just want to make sure that we recognize them as congenital malformation rather than neoplasm or any other underlying etiology. So here, the old days probably they thought that was a respiratory epithelium because of that bronchogenic cyst. Typically, focal duplication cysts are presented with a focal lung lesions, prenatal ultrasound, nicely demonstrating an aqueous lesion, well circumscribed, and the prenatal T2 weighted images nicely demonstrating the cystic lesion, and babies are born, and there's a correlating left hilar region, well circumscribed right lesion. Patients are also presenting with fever, elevated white blood cell count, and then also symptoms of the coughing, and you see some airflow levels with adjacent lung parenchyma abnormality, public consolidation. Those patients are infected, which can be seen up to 3 to 4% of the time based on the literature. But to be honest with you, initial presentation, I think it's much less common than older patients with infected bronchogenic cyst. As a radiologist, in order for us to tell whether we're dealing with cystic lesion or mildly enhancing solid lesion on enhanced CT imaging, what do? We put the Hansfield unit, right? But unfortunately, when it comes to bronchogenic cyst, sometimes close to 50% of the time, when you put Hansfield unit to see whether you're dealing with cystic lesion, it come out higher than water attenuation. The reason is because there's a lot of proteinaceous material within the bronchogenic cyst or focal duplication cyst. Hard to tell based on contrast enhanced CT. In that situation, I actually quickly used MRI as a problem solver. So here we have two different patients. When we put the Hansfield unit of this lesion, both of them came up higher than water attenuation. So we quickly performed just the one plane and one sequence without intravenous contrast. We did the T2 images, one on the top, light bulb bright, so you know that those are cystic lesion, and they was happened to be focal duplication cyst, bronchogenic cyst. One on the bottom was actually lymphoma, because it has an intermediate signal intensity, not light bulb bright. So in case you're not really certain whether you're dealing with high proteinaceous material, focal duplication cyst, versus mildly enhancing neoplasm, or solid mass on enhanced CT, you can quickly do T2 images with making the correct diagnosis. Now we're going to move on to congenital lobar emphysema or lobar hyperinflation, which result from, it could be extrinsic compression. Any of the thing that compressing the large airway, distal portion of the lung becomes actually hyperinflated, and they may present with hyperinflation. But it could be intrinsic compression, which can be seen up to 75% of the time. In that situation, they do have deficient or very weakened bronchial cartilage. Because of that, the flappiness, distal portion of the lung becomes more hyperinflated. Affected patient, particularly if they are infant, present with respiratory symptoms, dyspnea and coughing. People always talk about the common location. We do test in American Board of Radiology, so just wanted to let the trainees know. The most common location, left upper lobe, followed by right middle lobe, and the right upper lobe. They are the most common location. But as we know, multifocal congenital lobar emphysema do occur in pediatric population, so we should be familiar with it. A typical location, which is left upper lobe, followed by right middle lobe, and then right upper lobe. This is how the CT imaging presents. And then also, this is how clinically present usually on plain radiograph. Babies are born, I don't know whether you can recognize it, but there's a subtle lucency in the left upper lobe. The patient was not symptomatic at all. And this was a full-term baby, so they thought that everything was fine. They just put the NG tube. And 4 hours later, the patients are becoming more symptomatic. Now you see some more lucency left upper lobe. And now, 24 hours later, 1 day after the birth, next morning, the patient was really symptomatic with the left upper lobe congenital lobar emphysema. CT correlation, posterior view, nicely demonstrating left upper lobe hyperlucency, and underlying pathology, nicely demonstrating almost like an adult patient with a panlobar emphysema, right? So dilated alveolar space consistent with lobar emphysema. So for the trainees, so how many different types of lobar emphysema existing? Anyone? Anyone can tell me? Excellent, very good. Two different types, right? Answer is right there. So I think that we are all familiar with the type 1 congenital emphysema. But if you do enough chest imaging or pediatric radiology, you encounter once in a while the type 2 pulmonary, the congenital emphysema, which was actually initially diagnosed and then also reported by kind of my mentor, Dr. Cleveland. You know, Dr. Postcom worked with Dr. Cleveland, one of the probably the best chest radiologists, right? So when you visited was it 1998 you came? And then 2000, yeah, he was working at the time, but he retired 4 years ago. Anyway, so he recognized the fact that it is kind of odd. Older patient, meaning the fact that 4 or 5 years old, they're presenting with this areas of the lung, which is hyperinflated, and patient becomes symptomatic. But as a radiologist, the way we can tell something is a congenital versus acquired is we look at the prior study and compare, right? If it was there before, probably congenital. If it was not there before, probably acquired. But when it comes to type 2 congenital emphysema, prior imaging will be normal. So I'm going to explain to you how they usually happen. Type 2 congenital emphysema, that is actually classic form, meaning the fact that the portion of the lung, which is actually abnormal, they do have normal number of alveoli. However, they become hyperinflated. Because of that, they become loosened. When it comes to type 2 polyalveolar form, that portion of the lung which is abnormally loosened, they have from the start more than normal number of the alveoli. So alveolar itself is not hyperinflated, but because there are more number within that portion of the lung, they are loosened looking on imaging study. So important key factor is that when it comes to type 2 polyalveolar congenital emphysema, they present, and imaging wise, the characteristic lucency is seen much later than type 1, which is actually neonatal form of congenital emphysema. So I do have to say the fact that working at the large tertiary clinical center, I do see like one cases every couple of years of congenital emphysema, and then it's always like, well, you know, this lucency is developing 5 or 6 years old, and patients are now symptomatic, but prior chest radiograph done for pneumonia evaluation was completely normal. What is going on? So in that situation, you may suggest possible underlying polyalveolar type congenital emphysema. Prognosis really depends on a couple of factors. Nowadays, with surgical advances, no matter how big they are, surgeon can take it out. However, the problem is if the remaining lung is not that much, typically less than 25% of the time, affected patient, they don't do very well even after surgical section. Typically, if it's a large enough contralateral, means that shift to the contralateral side, as you can see here, with the attenuation of the vessel and bronchi. And as I mentioned to you before, some of the congenital emphysema is a multifocal. So here we did the nuclear medicine study sometimes demonstrating the fact that what part of the lung is normal and what part of the lung is abnormal. And as a surgeon, they try to save as much normal lung as possible, because if you take that everything out and remaining lung is not that much left, patient do not do very well. So here, you can carefully map what part of the lung is working and what part of the lung is not working. So one of the big advantages with the dual energy CT scanner that we just have in our institution, with perfusion imaging that we can do with the dual energy scanner, we can tell even what part of the lung is perfusing with the congenital emphysema and what part of the lung is not perfusing. So that became particularly important. That quickly leads us to our differential diagnostic consideration of hypollucent hemithorax that you may encounter in pediatric population. So these are the 4 different patients, all presenting with a right-sided hypollucent lung. So going back to 4th year, what's your name? Vegan. Excellent, very good. So vegan, normal, abnormal. First one, normal, abnormal. Abnormal, right? Excellent, very good. You did a very good job. Good, very good. So who's your best friend in your institution? Okay, who is it? Oh, excellent, very good. So great to be his best friend, right? So I'm going to show you same patient. So we did a left side decurious view. Can you tell me like what is causing this patient's right side hemithorax hyperlucency? Can you see it from there? Does it look loosened here at all on the top portion? Anything bothers you? So what could that be? Patient lying flat and then all this, something goes to the top portion of the hemithorax and there could be hyperlucent. So I know what you're going to say. You're going to say pneumothorax, right? Can cause patients hyperlucent hemithorax. Besides him, do you have any other friend? Yeah, who's your other friend? Very good, excellent, very good. Don't you just love to sit right next to him and become his friend? So normal, abnormal? Excellent, very good. So I'm going to give you a little clue. Hopefully you have a short-term memory. I know you weren't sleeping because you were paying attention. So what this could be, anything that we just talked about? Actually, we didn't talk about it before. So I'm going to actually answer on this one. This is actually due to CPAM, multifocal lung lesion. So we're going to talk about it a little bit later. So since you didn't answer it, what about this one? Excellent, very good. So we're going to talk about Orlova emphysema, right? Causing hyperlung lucency. Excellent. What about, do you have any other, like a female friend besides guy friend here? You have so many, you can decide. Okay, who's minute? Wow, excellent, very good. So what I'm going to show you is actually the last one, little bit older patient, right? And then I'm going to show you not the lung window, I'm going to show you the soft tissue window. And what is missing on right side compared to left side? Is anything missing? Excellent, very good. So start with what syndrome? Start with P. Excellent, very good. So Poland syndrome. So these are probably the four most common differential diagnosis consideration leading to hyperlucent hemithorax that may occur in pediatric population. We're going to quickly move on to CPAM and CCAM. I don't know how many people are really understanding some academic radiology, for example. So in order to be very famous in academic radiology, you have your own classification system, right? So everyone is actually using your classification system, and then they invite you, and then you go around the world and they give a lecture. But 20 years later, you are not creative anymore, so you cannot come up with anything new. So next thing that you do is you upgrade the system. Now you have something new. So when you look at 80s music stars, how many people love 80s music? Raise your hand. Yeah, I mean like 80s music. So all these 80s music stars, like they are not creative to come up with new song, but now they have like a different, like a rhythm or something with the same song, and now they have become more popular and they sell more records. Not that doctor who actually have this new classification did that, but after practicing 20 more years, Dr. John Stocker, he's actually at AFIP, he's the pathologist. He realized the fact that initially he thought that there were 3 different types of the CCAM, but there are actually 5 different types. So he upgraded the system to 5 different types, and then he named actually CPAM, which I'm going to show you a little bit later. Before we go there, when it comes to CCAM or CPAM, we're practically talking about malformed lung congenitally, and that is not actually associated with abnormal vascular structure. And they do have normal communication with adjacent bronchial tree, which is a very important pathological distinction from sequestration that we're going to talk about a little bit later. So here, this is the old classification system by Dr. Stocker. Type 1, large cyst, individual cyst is a greater than 2 centimeter, accounting for approximately 50% of the time. And type 2 is a multiple cyst, as you can see here, but they are small. And type 3, I find it very interesting. Any of the imaging studies, even CT or MRI, you give the contrast, mildly enhancing solid lesion, but when you do pathological evaluation with a high power, there are multiple tiny cysts, as you can see here. Because of that, it's a part of the congenital cystic lung malformation. A couple years ago, Dr. Stecker upgraded it, and then at least he kept previous classification system, so it's not really confusing. So he kept type 1, 2, 3, and then he added 2 more, type 0, which is a rarest form. I'm going to show you. Malform, small and firm lung, which is incompatible with life. And type 4 is a large cyst, multiple of them, almost like a type 1, but there are multiple of them located in the peripheral portion of the lung. And they have a mediastinal shift to the contralateral side with a poor prognosis. I really think that because now we do more prenatal imaging, I recognize the fact that Dr. Stocker probably never really seen type 0 before because these are in utero demise. And a lot of times, particularly in America, in utero demise, they really didn't do, or infant just born and then died, they didn't do biopsy 10 or 20 years ago, or pathological evaluation. However, autopsy. Nowadays, patients' parents want to know more and more about what happened to their child for their second or subsequent childbirth. Because of that, we are finding more and more about it. But these are the type 0, 1, 2, 3, 4. So here, imaging findings: type 1 on CT, large cyst, individual cyst greater than 2 centimeters. Type 2, multiple cysts. Type 3 is a solid lesion, mildly enhancing, but it doesn't have associated abnormal vascular structure. We are now adding type 0, in utero demise, so probably no imaging study. But when you actually look at pathology, do you see particular left lung, how firm and small? And these are like the airway, trachea, and the left means and bronchi, diminutive. The patient really cannot survive in this situation. And then type 4, of course, there are multiple large cysts located in the peripheral portion of the lung with a mediastinal shift to the contralateral side, and the pathological correlation: type 1, large cyst; type 2, multiple tiny cysts; and type 3 is a cyst, but they are microscopically, but they are solid lesion. And type 4, large cyst located in the peripheral portion of the lung. As a radiologist, we just have to recognize them. These are congenital lung malformation. So prognosis of the CPAM depends on a couple of things, as I mentioned to you before with the congenital emphysema. Size of the lesion matters. Associated remaining pulmonary hyperplasia, and then also associated other congenital anomalies, typically heart disorder. And then one of the things that we are finding more and more about with the CPAM is the fact that if you leave it alone, I do believe the fact that there's increased risk of superimposed infectious process. So this patient's mother was actually a doctor. Having a doctor as a mother sometimes can be challenging, right, as a physician. So here, the mother did not want her to have actually surgical scars. So, some of the CM or congenital malformation, they may just spontaneously resolve. So they've been kind of following up, unfortunately, presenting with a lung abscess with a superimposed infection. So difficult to take it out and became more complicated procedure. How many people heard that if you leave these lesions alone, it may develop into neoplasm? How many people believe that? Raise your hand. Not many people? Oh, you do. Okay. Soraya, you're the only one. Are you sure you believe that? Where did you hear that from? Oh, really? Oh, so I was doubtful, like, is that really true? You know what I mean? So, people talked about in the literature, so maybe that's true, but until I encountered this particular case. So it was interesting, same thing, patient parents, mother and father, from different countries, somewhere in the Middle East, and they didn't want her to have like surgical scar. So they come to our hospital every couple of years and then get CT imaging, flying all the way, And then we noticed the fact that this cystic lesion, which started very small, was getting bigger and bigger and bigger. And then, I don't know whether you recognize it from the part. Some of this septation becomes thicker and then become a little bit more nodular. You see this area? Kind of bothered us. Because of that, we eventually took it out surgically, and then it was actually bronchoalveolar cell carcinoma. Not sure whether it was starting from lung neoplasm, but because of this particular two reasons, if you leave it alone, increased risk of infection and potential rare possibility of possible neoplasm. Because of those two reasons, if you mention that to American parents, they all want those lesions to be out. So in our hospital, most of the cystic lung lesion above chest CT, if it's still there, I like to take it out. And in that way, it's more safety for the patient, and we get more pathological information of what it is. Okay, that leads us to another interesting case. 2-month-old boy presenting with respiratory distress. So going back to you, normal. Okay, which side is abnormal? Right side or left side? Very good. Excellent. Okay. So who's your best female friend besides your wife? What? Okay, so I'm just gonna ask you, does it look single or does it look multiple to you? Okay, very good. Next person, what's your name? Okay, excellent. Do you like radiograph or do you like CT better? Okay, very good. I'm giving you everything. So CT, normal, abnormal. Okay, so correlating very well with what we see, right? With the plain radiograph. Multiple cystic lesions, some of them look like a septated. Okay, who's the person sitting right next to you who fell asleep at the beginning, but I know you're awake. So you can get this one right. So what's your name? Okay, you're second year, third year? First year? Okay, great. Your first year, I give you a choice. So this is, so I'm the chair of American Board of Radiology, pediatric section. So this is exactly what we do. Simple STEM, one or two sample images, and then we give 4 options, and then hopefully you get it right. So with this imaging findings based on the plain radiograph and CT, what is most likely diagnosis? Number 1, could that be CCAM or CPAM? Could that be congenital lobar emphysema? Could that be bronchial atresia? Or could that be pulmonary blastoma type 1? So those are the 4 different choices. Don't Google, I can see you from here. Oh, the iPhone is off. So I'm going to give you a little time, and then you're going to vote. Life is full of tough decisions that you have to make. Okay, so what is your choice? Number 1? Okay, so how many people here think that he's right? You want to support him? Raise your hand. Okay, God, you don't have a lot of people supporting you. So how many people think that number 2 is the right answer? Raise your hand. Okay, how many people think the number 3 is the right answer? We all have to participate. Okay, how many think number 4 is the right answer? Okay, wow, very interesting. People in front row pick number 4. People in the upper row pick number 1. People in the middle, they are not participating. Anyway, so how many people love American TV show Who Wants to Be a Millionaire? Couple people. So in that show, if people are not doing very well, they eliminate 2 choices. So you become to have just the 2 options, like a flipping a coin. So if you get it wrong still, it's very embarrassing. So what I'm going to do is I'm going to eliminate 2 choices, and you're going to pick one, okay? So what I'm going to do is I'm going to eliminate choice 1. So that's not the right answer. You look so disappointed. And I'm going to eliminate option number 3. So now you have number 2, congenital emphysema, or could that be number 4, pulmonary blastoma? And we are going to vote. So how many people think it's number 2? Raise your hand. Nobody. So how many people think it's number 4? See how easy that could be? Excellent, very good. So hopefully you know what it is and got the question right. But anyway, so this is actually pulmonary blastoma type 1. I just really want to emphasize this. The reason is because there are 3 different types. Definitely we did a surgical resection and it was actually malignant lesion. And then there are 3 different types, type 1, 2, 3. Type 1 is a rare form, but it's a pure cystic lesion. They look exactly the same as type the congenital congenital CPAM. Because of that reason, really hard to tell from one another. Because of that particular reason, surgical resection is currently actually recommended in patients with DISO1 genetic mutation. So I don't want to spend a lot of time making it more complicated. But now we've found what is causing this patient with pulmonary blastoma is underlying genetic mutation called DISO1 genetic mutation that leads to oncogenesis. As a radiologist, important thing is the fact that when someone has a DISO1 genetic mutation, that is an autosomal dominant condition, and it affects other family member. So if you see one patient with pulmonary blastoma, sibling or other family member presenting with a focal lung lesion, which is cystic, they need to come out. More than 78 to 90% of the time, based on our experience at Boston Children's Hospital, working very closely with oncologists at Dana-Farber Cancer Institute, we found that most of them has underlying pulmonary blastoma, even they are asymptomatic in children. We also start finding patients with pulmonary blastoma, they not only have a lung neoplasm, they have a other neoplasm, other part of the body. So this patient presented with abdominal pain. Young patient, because of that we did the ultrasound and we saw intussusception and there's a little polyp causing as a lead point, and then one on the top during the intussusception reduction we also saw some lucency, so we did a CT imaging. Patient had a cystic lung lesion and a jejunal polyp which was taken out, and both of them, one on the top was a chloroplastoma and the bottom one was jejunal polyp. Patient with a DICER1 genetic mutation, they have a polyp formation in the small bowel in children. Because of that, they may present with intussusception as a polyp lead point. What about this one? The front patient, another cystic lesion, as you can see here. Clinician thought that they felt something in the abdomen. Because of that, we did the ultrasound and we did MRI. Multiple cystic lesion, one single lesion with a multiple septation in the kidney, and the kidney lesion was taken out. One on the lung was actually chloroplastoma type 1, and then the kidney lesion was cystic nephroma. So those patients has a high increased risk of other tumor besides cystic nephroma and chloroplastoma, and then also jejunal polyp. You can see ovarian sertoli Leydig cell has an increased risk of developing in patients with a DICER1 genetic mutation and any of the primary neoplasm involving the eye. So those are the areas that you need to definitely pay close attention. Okay, we're going to move on to bronchial atresia. For the sake of completeness, as we all know, we just have to recognize these are the segments of bronchi that's not communicating with adjacent central airway. It's a bronchial mucosa. We just have to recognize those air trapping around it. The nodular mucus plugging with some air trapping. We should not recommend biopsy or resection and recognize this as underlying congenital malformation. When it comes to bronchial atresia, I do have to say the fact that now it's getting much more attention than before. The reason is because one of our actually colleagues from Boston Children's Hospital, what she did was very interesting. As a pathologist, whenever there's a surgical resection of the lung malformation, they usually look at very high power microscope. And what she did was she looked at these lung lesions with a low power dissecting microscope. And what she found was that a bronchial atresia was present in high percentage in high frequency in other type of the lung malformation, which includes pulmonary sequestration, particularly extra lobar sequestration, and CPAM and congenital emphysema. And what they're postulating is all these different type of the lung malformation is due to at what stage of the lung development there was air blocking. Those bronchial atresia was present. And depends on the stage of the air block or bronchial atresia development, they may lead on to different type of the lung malformation. Do I believe it? I think that I do believe to a certain degree, meaning the fact that that explains lung parenchymal, pure lung lesions, but some of the lung malformation, which I'm going to show you a little bit later, as we all know, they are also associated with vascular component, which is now really explained by this bronchial wall obstruction during the developmental phase. So I think there's a multifactorial. However, this is one of the postulation of how it's developing regarding pure lung parenchymal lesions. Okay, we're going to move on to some hybrid lesions before I move on to different category. So famous pediatric radiologist, Dr. Coscom knows all the famous pediatric radiologists in America. Dr. Don Griscom, when I was a fellow a long time ago, before he retired, he passed away 2 weeks ago. Unfortunately, he used to tell me, Ed, whenever you see something really odd looking in the lung, besides thinking about zebra, I don't know, you say the same thing. If you see something really abnormal, it's like you saw zebra. Am I right here? Do you say the same thing in Turkey? So I was giving this talk in South Africa, Johannesburg. They said zebra is everywhere. So we don't say it's a zebra. But anyway, so he always mentioned about the fact that instead of thinking about something really, really unusual differential diagnostic consideration, Think about lung hybrid lesion, for example. In this patient with a bronchial atresia with a congenital emphysema, multiple type 2 CPAM with a congenital emphysema. This one actually had an AVM with underlying congenital emphysema. So you always want to think about hybrid lesions before you get to more esoteric and more complicated severe type differential diagnostic consideration. Since we talked about abnormal lung with a normal vasculature, now we're going to quickly move on to normal lung with abnormal vasculature. In this category, I want to highlight two very important topics in both pulmonary artery and pulmonary vein. Of course, we should not forget about pulmonary artery stent. We talked about during my first presentation, so I'm really not going to go into detail, just a quick review. And of course, we should think about some shunt lesions, such as a pulmonary AVM and then a PDA. And when it comes to pulmonary vein, I really want to introduce the pulmonary vein stenosis that occur in infant and young children. How many people are really familiar with primary pulmonary vein stenosis in children and infants? Raise your hand. Do you see a lot? Here? Not that much? You missed one. So I'm actually going to present that to you because a lot of times diagnosis is really not made on timely fashion. And of course, as a radiologist also, and in board exam, a partial anomalous pulmonary venous return. Since we talked about this, given the limited time, we're not going to spend a lot of time, but pulmonary artery stent, as I mentioned to you before, anomalous left pulmonary artery arising from proximal right main artery, pulmonary artery. Because of that, they go swings around the distal trachea, so main pulmonary artery stent came up. Type 1, as we all know, is the one associated with compression of the posterior aspect of the trachea, anterior aspect of the esophagus, and right nasal bronchi. Patient may present with air trapping. And then 3D bone rendered images, really nicely demonstrating what part of the airway is compressing, looking from the posterior view, pulmonary artery swing. And then here, distal trachea and left nasal bronchi, and right nasal bronchi is compressed because of that. Patient presented with hyperinflation. And type 2, as we all know, is the one associated with long segment tracheal stenosis. So you want to pay close attention to patient with type 2 pulmonary artery stent. And I say a friend lesion, one friend always like to go with other friends. So when you see one anomalies, you always want to look for other anomalies have a frequent association. Right lung agenesis is associated with pulmonary artery stent, hyperplastic, and pulmonary artery stent is associated with type 2 long segment tracheal stenosis. So this one has all association in one same patient. Next, we're going to talk about a couple of shunt lesions. PDA, as we all know, is shunt blood in utero from right ventricle to aorta. It has a very important function bypassing the lung during in utero. And after babies are born, typically functional closure occurs 12 to 24 hours after birth, but anatomic closure happens a little bit later. People living at high altitude, and particularly in America, a lot of patients with complex congenital heart, they may need to have PDA open to have a blood supply. It becomes important. You just have to recognize the true communication between aorta and the pulmonary artery. I do find sagittal multiplanar very helpful looking at the direct communication. For the reston, one thing that is a normal variation is actually ductus bump, a little outpouching in the aorta. You should not actually mistake that as true PDA. True PDA, as you can see here, there's a shunt going on between aorta and pulmonary artery. And when it comes to just ductus bump, it's a little outpouching. I do actually have to say the fact that one of the radiologists made a mistake as aortic pseudoaneurysm or dissection in actually trauma patient, and it was actually just ductus bump, and then they thought that there was an aortic injury, not recognizing this is kind of normal variation. We're going to talk about pulmonary AVM. In this condition, as we all know, there is a direct communication between pulmonary artery and vein without intervening capillary bed. Pediatric population. A lot of times these are small and they are not multiple because of that reason. Patient may not be symptomatic. But when you see multiple pulmonary AVM, what syndrome or disease do you want to think about? Excellent, very good. So also Randy-Weber disease or hereditary emergent telangiectasia, autosomal dominant condition. multiple pulmonary AVM. We want to screen the family member because approximately 50% of the time they will have a pulmonary embolism. If you leave it alone, they may actually have paradoxical stroke. And this was kind of interesting case where the patient presented with multiple pulmonary AVM and family history, the grandfather and then everyone died of the stroke. And we don't know what really caused, but we can postulate maybe they also had underlying pulmonary AVM. One of the imaging techniques that I always use, particularly in pediatric patients with pulmonary AVM, is actually maximum intensity projection images. So the real time, actually my fellow was mentioning about the fact that totally on the right lower lung, it looks like a nodule, looks like mucus, I don't know what it is. And then that's a regular soft tissue window technique. So we just make them or maximum intensity projection images increase to 8 millimeter, and you can actually characterize it better. Abnormal artery going in, and there's a nidus and the abnormal vein draining out. The connection can be clearly visualized. The small pulmonary AVM, I do strongly recommend to perform maximum intensity projection images. I find it that the sagittal really helpful in addition to axial plane. This one unfortunately does not really work, but just wanted to show you 3D volume rendered images. The size, number, location, and then the draining vein and the feeding artery can be very clearly visualized. Very helpful information, particularly for our interventional colleague. I don't know who's doing embolization procedure in Turkey, but in America, we as a radiology, our colleague interventional radiologists, provide the management of this patient. So today, most of the lesions that I talked about is probably something that you know with updated information, but I just want to leave you with something that you are probably not really familiar with, which is actually primary pulmonary vein stenosis. In adult patients, who gets pulmonary vein stenosis? Anyone? Some kind of procedure done, right? Obliteration procedure, and they have ischemic changes and they get pulmonary vein stenosis. In pediatric population, this is actually due to uncontrolled growth of myofibroblastoid connective tissue. So when something is growing in uncontrolled fashion, it is neoplasm. So once you make primary pulmonary vein stenosis, these patients are now getting treated with gliobec. That's a chemotherapy agent. So very important for us to actually recognize them. So we're going to start with some pathology. Here, this is actually normal cross-section of pulmonary vein, nicely stained. As you can see here, the lumen is actually patent and the wall is very thin. In comparison to a patient who died of the pulmonary vein stenosis, entire lumen is obliterated and the wall is very thick. And when you look at a gross specimen, this is a pulmonary vein. The thickness is as thick as adjacent pulmonary artery and the bronchus. As you can see here, that's narrowed, and bronchus and arteries are patent. So this patient unfortunately did not do very well. Imaging-wise, very characteristic imaging appearance. Smile enhancing or low attenuation soft tissue. This patient had left-sided pulmonary vein obliteration, and when you see this dark area not enhancing that much, those are the myofibroblastoid soft tissue obliterating pulmonary vein in comparison to patent right pulmonary inferior vein. And then as a radiologist, very important to actually talk about location. Just like buying a house, location becomes important, and degree, and then also extension. Short segment, high grade narrowing involving very proximally. You can do balloon dilatation, stent placement, or even primary surgical resection to end-to-end anastomosis. But if it's involving multiple all pulmonary vein going all the way to distal pulmonary vein, for example, this patient had a proximal pulmonary vein stenosis and mid pulmonary vein. Do you see that is how narrow and small compared to other pulmonary vein? Those patients may need to undergo lung and heart transplantation. So this is one of the indications for now in pediatric and infant with the lung and heart transplantation. I did find 3D volume rendered images very helpful looking at actually a pulmonary vein stenosis. So we perform CT angiogram, timing it at the left atrium when contrast enhancement is greater than 150 or 200. That's when we actually scan the patient. The entire left inferior pulmonary vein is involved with another tight stenosis involving the the proximal portion compared to right side pulmonary vein, which is actually well patent. So very helpful information can be obtained. Next, we're going to talk about other important and mini in the pulmonary vein involvement, which is a congenital nature, which is a pulmonary vein, partial anomalous pulmonary venous return. Hopefully some other time when I come back to Turkey, we'll talk about some congenital heart disease, but today, at the time, I'm going to talk about total anomalous pulmonary venous return, but today we're going to focus on, because we're talking about the lung, and partial anomalous pulmonary venous return. As we all know, pulmonary vein typically drain into left atrium, but in this condition, a pulmonary vein may not drain into left atrium. It could be one or multiple. And typical type of connection, as we all know, right upper low pulmonary vein to the right atrium superior vena cava and acigus vein. And when it comes to right low pulmonary vein into IVC, portal vein, and hepatic vein. And when it comes to left upper low, precristocephalic or hemiazigus vein. Couple key points to start with. Right side is much more commonly affected than left side, and usually asymptomatic, but as I mentioned to you before, if there are multiple affected patients may present with symptoms. Here, typical and mini and American Board of Radiology favorite question. So here, patient had right upper lobe, partial anomalous pulmonary venous return draining into superior vena cava. It is associated with what underlying intracardiac heart defect? Anyone? Anyone can tell me? Type of ASD? Excellent, very good. Sinus venusus defect. Here, as you can see here, this is actually direct communication between at the level of the atria, very high in location, has association with underlying right upper lobe partial anomalous pulmonary venous return. What about this one? Typical left upper lobe partial anomalous pulmonary venous return. Here, draining up to the vertebral vein, as you can see here. And then there's abnormal vascular structure located in the paramediastinum on the left side. That leads us to differential diagnostic consideration of left paramediastinal veins, which is enhancing, which may be seen when we actually evaluate the patient. So we have three different patients with a very similar imaging findings of abnormal vascular structure located at the level of the aortic arch on the left side. Can you see them? Right? Okay, so we're going to start with you again. Excellent. So, what do you think about the diagnosis of the first one? Does it ring a bell? Does it look very same as these images? Yes, very good. So, what is the most likely diagnosis for the first one? Short-term memory. So that is actually left upper lobe partial anomalous pulmonary venous return. Excellent, very good. So next one, very similar imaging findings. Anyone can tell me what the next one could be? What? Left superior vena cava. Okay, how many people think that she's right? She has a very famous textbook, so she must be right. Am I right? Okay. Very good. So this one actually duplicated on left side is superior vena cava. In this condition, you follow the vein, go down, and then draining into coronary sinus. So third one, X-rated diagnosis. Some people think that on plain radiograph, you may see aortic nipple. And anyone, does it ring a bell? So this one is actually superior left intercostal vein, as you can see here, that because of their location, you may have a little indentation or round or oval opacity right next to aorta, so on plain radiograph of the aortic nipple sign. So these are the probably three most common differential diagnostic consideration of left paramediastinal vein you may encounter in pediatric population. So just quick review, and then we get to the last two important diagnostic consideration. So quick review of partial anomalous pulmonary venous return. So right upper lobe, typically draining into superior vena cava. It is associated with what defect? Intracardiac. Excellent. Sinus venusus defect. Left upper lobe typically isolated and they're draining into vertical vein. And the left lower lobe is really rare, but that's the common location for pulmonary sequestration, which we'll talk about a little bit later. And when it comes to right lower lobe, typically draining into IVC, portal vein, hepatic vein. It could be isolated findings or it could be associated with Scimitar syndrome. That leads us to our last category of Category of abnormal lung with abnormal vasculature. In this category, we have two very important topics, which is Scimitar syndrome, also known as hypogenetic lung syndrome, and of course, pulmonary sequestration. We're going to start with the Scimitar syndrome, also known as hypogenetic lung syndrome and pulmonary Orlova syndrome. In this condition, as we all know, right low lobe and sometimes middle lobe vein is not draining into correct position, but typically into IVC, portal vein, hepatic vein, or even sometimes directly to right atrium. But they do have very characteristic and mini imaging appearance. So plain radiograph, you see small hemithorax, and now I'm talking about this in Turkey. I can confirm from you whether that really looks like scimitar sword. Does it really look like scimitar sword? So I went to Oman, and then they also have like this sword, you know what I mean? But I thought it would look very similar to scimitar sword, but they said that the true real ones are here in Turkey. But anyway, so because of that appearance looks very similar of the scimitar sword, the name of the scimitar syndrome came up. And imaging-wise, you just have to recognize where they're draining into. For example, here in this patient with a large, the partial venous return, middle and the lower lobe draining into IVC. Look for other congenital heart disease, which is associated with ASD, BSD, PDA, and tetralogy up to 25% of the time. As I mentioned to you before, nowadays embolization procedures are very popularized, done by our interventional colleague. So large scimitar syndrome with a scimitar vein here draining into IVC. And then pores extension and then also size matters for our interventional colleague for preoperative information. How many people have seen horseshoe kidney? Raise your hand. Okay, good, very good. So how many people have seen horseshoe lung? Raise your hand. Just a couple people. You saw everything. Is it in your textbook? Anyway, so here just wanted to show you up to 67% of the time, patient with the scimitar syndrome is associated with horseshoe lung. So just the bottom and posterior portion of the lung is kind of fused together. Based on the literature, they said patients with horseshoe lung, they have an increased risk of infection. But the ones that I've seen are more incidental finding, patients with underlying congenital heart disease. So I haven't really seen in patients presenting just with a posterior lung infection, but I don't know, do you have any? Not that much, right? But on the literature, that's what they are mentioning in typical clinical presentation, but I'm not really sure whether there's correct information. Okay, so lastly, we're going to briefly talk about pulmonary sequestration. In this condition, as we all know, there's abnormal malformed lung. There's no direct communication with airway and pulmonary artery. Intralobar, extralobar sequestration. So, since your husband is a pediatric surgeon, am I right? Emergency. Oh, any pediatric surgeon here? What? Anyone? Pediatric surgeon sitting here? Don't be shy. But surgeons are usually not so shy. Okay, so they're not here today. So what I'm going to do is I'm going to ask you a question. If you are a pediatric surgeon, which one would you prefer? Intralobar, extralobar? You know they're lazy. Extralobar, right? Because they want to see something well presented to them. They just want to scrub looking great and then go in there and just take it out. Right? But when it comes to pediatric radiologists, which one would you prefer? Extra or intralobar? Also extra? No. I do have to say that as a pediatric radiologist, the vascular malformation associated with intralobar sequestration is so much more predictable. I actually personally prefer intralobar sequestration because extralobar sequestration, you have to spend time look for those abnormal veins and everything where you're draining into. So busy clinical setting, I like intralobar sequestration better. In the past, this is actually the table people presented all the time, so I just wanted to show it to you. They think that intralobar sequestration acquired presenting older patient with recurrent infection, extralobar more congenital, and then they are encapsulated with their own lung flora. But nowadays, with prenatal imaging evaluation, we see that there's a lot of overlapping. Some of the in utero pulmonary sequestration is also intralobar sequestration. So I just want you to recognize the fact that still people use this intra and then extralobar sequestration. But the important part is when it comes to extralobar sequestration, more variety of the venous drainage and then also arterial supply. So you have to pay a little bit more close attention. So intralobar, extralobar respiration, intralobar well encapsulated with their own lung flora. Extralobar respiration is not, so with the surgical resection, underlying pathology, same thing. Malformed lung doesn't have any connection to adjacent bronchial wall or tree, and then has abnormal vascular supply. Typical intralobar respiration, large artery coming from descending aorta to pulmonary vein with an inferior ipsilateral pulmonary vein drainage. Very typical presentation, predictable course of the abnormal vessel, so I like it better. When it comes to intralobar sequestration, sometimes, as I mentioned to you before, we as a radiologist need to pay very close attention. So when we did the XLCT data set, we only recognized this large lumbus vessel arising from descending aorta, but we thought that that's probably one of those collateral. But when we did the 3D imaging, as you can see here, we can see there's a two artery coming. So if we didn't mention this small artery, surgeon with a trocar placement, they probably ligated this and trying to pull this out without ligating the small one, not knowing there's another small artery. And what do surgeons do when something doesn't come out? They yank it harder, right? So one of the cases that I was consulted was from actually unfortunate child in Brazil. That's exactly what happened. What happened was the fact that there was a two abnormal artery, and then the bottom one was not recognized, and the surgeon, it wasn't coming out. So, video scope, and then the lung was deflated, and in front of his eyes, he just pulled it, and then everything just went black because it's all hemorrhage. And then it was really hard to find second abnormal artery. So we have Terry Buckmiller, who does all this surgery, and then one time I mentioned about, I think that there's two large vessels, so make sure you ligate both of them before you take it out. And then she texts me, are you sure? So I text back, CT don't lie. And then next day she sent me nice corresponding images. So there's a two large vessel arising from descending aorta, corresponding very well with what we see on CT imaging. Extralobar respiration, very interesting here. It's draining into all the way to actually atrium. So as I mentioned to you before, 2D and 3D imaging, in order to make the diagnosis, it may not provide additional diagnostic information, but when it comes to vessel evaluation before the preoperative assessment, it really does. For example, here extralobar respiration, in this case, actually abnormal vein is draining, crossing the midline to the right atrium. Internal memory vein drainage. And what do we do with this? So one large artery arising above the diaphragm, one large artery arising below the diaphragm, they join together and draining. So should we go from top and bottom together at the same time? Surgeons do not want to open up the chest and abdomen at the same time. So in this situation, we planned it. We actually ligated the bottom one first, interventional radiology colleague, and then we actually just went in intrathoracically to actually ligate the top portion. So angio architecture evaluation becomes particularly important because it changes spatial management. Okay, before I end my presentation, I have to bring something interesting. So this is my last case for this presentation. So hopefully, who's a second year resident? This is kind of second year resident case. Raise your hand, don't be shy. Nobody is second year? Okay, what about third year? Raise your hand, don't be shy. Nobody wants to do this. Okay, so I'm going to point out someone. Someone who's just sitting way back. Are you a trainee with a blue shirt? No, the one up the top. Yes. Don't you just love it? Like a blue? Yes, I'm blue. What year are you? Are you a radiologist? Okay, excellent, very good. Very good, so I'm going to ask you a question. So this one was actually on-call case. So my resident was actually looking at this case, and then the clinical history was like a fever and then intermittent chest pain. So we obtained chest radiogram, definitely abnormal, right? Right side is abnormal or left side abnormal? We thought the left side was abnormal, and then my resident thought that could it be pneumonia? Because of that, we made a diagnosis of the pneumonia. And then the ER physician, I don't know how you do it here, but do you guys perform fast ultrasound in ER by ER physician here? Not really, right? In America, they're not supposed to do it, but they do it all the time. But anyway, so in ER, they just quickly put the probe, and then they like, just to confirm, just the pneumonia and how much effusion is there to tapping. But do you think there's just something around there? Yes, no? Yeah, so they were actually concerned, meaning that, oh God, there's effusion, but there may be something there. So this was performed by the ER physician, and then he called us back. What do you think that is? It looks very odd. So we actually performed CT study. So I'm going to ask you a question. So do you see findings? Don't you love my red arrows? Yes, no? Good, excellent. Do you think it's enhancing or not enhancing? It's dark. So aorta is really brisk, right? But doesn't look like enhancing. And then we also some punctate calcification. So with these imaging findings, what is the most likely diagnosis? Anyone? Neuroblastoma, excellent. That was actually top on my differential diagnostic consideration. Kind of paramediastinal region, kind of not enhancing that much, but that calcification. Anyone else? Okay. So my best friend is a pathologist, Sarah Vargas, and my second best friend, well, I don't know whether he's my best friend, but he's a surgeon. So, so CC Jackson sent me this. And then Ed, please, before you finalize your report, put your differential diagnosis consideration. What? So when you actually look at it here, something is going around the vascular pedicle, right? So just wanted to show you. So I'm going to go do one more time here. So there's a devascularized something, and then there's a third vessel, and then this is going around, and then these are the normal vascularized lungs. So something is kind of going around, and it looks really dark here, right? So with these imaging findings and some intraoperative images, what is the most likely diagnosis? Anyone? I think I heard it. So this was actually torus extralobar pulmonary sequestration. So diagnosis was interesting, but the more interesting part was this boy's parents saying the fact that we've been telling ER physician, and I said like, what do you mean like you've been telling what? My son had a testicular torsion 3 years ago, and it's the same pain, but it's in the chest. They didn't listen to me, and I'm like, oh well, So this was actually a case of the extralobar pulmonary sequestration, which was actually torus because of it's a torus. It's not really enhancing, it's not really vascular. So also it's probably, when you look at the pathology, this microcalcification, it's a dystrophic calcification. So it's been torsing for a while. So there's actually dead cell with a calcific formation, mimicking a neuroblastoma. Thanks God, I did not finalize my report yet. Anyway, so given the limited time, what I did was, we talked about some congenital malformation. In order to make the correct diagnosis, if you kind of categorize them into whether you're dealing with abnormal lung with a normal vasculature, or abnormal lung with abnormal vasculature, and normal lung with abnormal vasculature, it becomes much easier to generate the differential diagnostic consideration. Making the diagnosis, axial CT, after prenatal imaging study and plain radiograph is sufficient enough, but for those vascular components, doing the 2D and 3D imaging for precise assessment, for preoperative assessment becomes particularly important. Thank you very much for your attention.
Soruya katkı var mı?
I want to ask you a question about type 3 CPAP.
Yes.
Can we differentiate or diagnose type 3 CPAP by MRI instead of CT interpretation? Because we know we can clearly see highly cyst with ultrasound or MRI. Do we have any experiments?
Okay. So in our institution, currently in the past decade, like 15 years, we've been doing CT imaging rather than MRI. So in terms of what I've seen, it's limited. But one of my collaborators, his name is Pierre Siet from Rasmus Hospital in Netherlands. and then they do a lot of MRI imaging. And then what he's saying, I remember discussing about this particular thing, he still does not see those tiny micro cysts. So we know the fact that on cross-sectional imaging studies, whether you're dealing with CT or MRI with contrast enhancement, it's just a solid lesion, so it has to come out. But underlying pathology is actually there are multiple tiny cysts.
Evet arkadaşlar 15 dakika ara veriyoruz. Sonra dinin son sunumuyla devam edeceğiz. Afiyet olsun. Yok, vallahi gereksiz. Güvenmiyorum.